I'm Dr. Mikhail Anderson. I'm a professor in the Department of Surgery and the president of UWP, the practice plan here, and one of the two chairs for Mini Medical School 2016. Jenny Brody, my partner.
Good evening, nice to see you all again. I'm Virginia Brody. I'm an internist and hematologist oncologist and the vice chair of the Department of Medicine, and I see patients at Harborview Medical Center, our county hospital.
Thank you. So a couple of cautions. Please turn off your pagers and cell phones. You heard about the video and flash photography. And the video of this session will be available for you on the website tomorrow. The other disclaimer is please don't try to practice any of the medicine you hear tonight independently. We'll help you with that. So, this is UW Medicine, Mini Medical School within UW Medicine, with a particular goal in our community of advancing medical knowledge, of providing outstanding primary and specialty care to the people of our region, and training tomorrow's physicians, scientists, and healthcare professionals. In UW Medicine, we have a number of independent entities which all link to UW Medicine. You can see them up on the slide. Harborview Medical Center, UW Medical Center, just down the hallway, Northwest Hospital and Medical Center Valley, the UW Neighborhood Clinics, UW Physicians, our School of Medicine, and Airlift Northwest. And they are all partners together to form UW Medicine. Mini Medical School, as those of you who are back for now the fourth session know, Mini Medical School is designed to inform you in an interactive way, so we look forward to your questions about biomedical sciences, from research to patient care, to help you understand what's involved in medical training, and to invite you both as family members, as patients, and as members of our community to partner with us in support of excellence in medical science and patient care at UW Medicine. And of course, we want to make sure that you have fun. Just a brief reminder, we have two more sessions, March 1 and 8. The next one coming up, Coping with the Most Serious Illness, Randy Curtis and Tony Bach, both from our palliative care department. And then the last session on March 8th, Suzanne Allen, Dr. Suzanne Allen, talking about rural medicine, rural practices of medicine within the WWAMI region. So we look forward to having you join us for those two. As I said, the presentations are available the next day on our website. This is being taped. Please turn off your cell phones and your pagers and look to the website to get any further information.
Thank you, Mika. And it is now my pleasure to introduce our speaker this evening, Dr. JoAnn Elmore. For those of you who are alumni of Mini Medical School, you will recognize Dr. Elmore, as she was one of the co-chairs for several years of the Mini Medical School. She is a professor in the Department of Medicine and an adjunct professor in epidemiology. She received her RWJ clinical scholars training at Yale, and 6 years later was running the RWJ program at the University of Washington. She received her MD from Stanford and then received training in both internal medicine and epidemiology at Yale, and then we were fortunate to recruit her to the University of Washington. Dr. Elmore is an expert in the benefits and risks of breast cancer screening and in the diagnostic accuracy of pathologists, in addition to her very creative study on OpenNotes that she's going to tell you about this evening. But perhaps even more impressive than her own research accomplishments is the fact that she has both inspired and mentored a very large number of junior faculty members during their first research experiences and help them to succeed and enjoy research. She's just been an inspiration to the faculty. She takes care of patients in the adult medicine clinic at Harborview Medical Center. And on a personal note, I'd just like to mention that Dr. Elmore and her teenage son Cole spend their Thanksgivings volunteering, feeding homeless people at one of the shelters in Seattle. And I just found that so impressive that this scientist and clinician would spend her Thanksgivings together with her son and do that year after year after year. So please help me to welcome Dr. Joann Elmore.
Thank you. It's good to be back. It was many years ago that I had the pleasure of working with Hugh Foy and attending these wonderful lectures. So I'm honored and I'm looking forward to this. The title of my talk is Doctors and Patients on the Same Page. And you may wonder, what in the world is this about? I'm going to talk about opening up patient portals so that you can access everything in your medical record. I want to increase patient engagement. I want to have you help us take better care of you. Now, we have a tradition in medicine of starting our talks with case vignettes. It's a time-honored tradition, and I would like to follow through with this. I do need to dim the lights a little bit so you can see this. This is me, my dog Maggie, and my mother. And so I'm going to share with you a personal vignette. I'm healthy, I don't go see doctors myself as a patient, but when I was pregnant, I did go to see an obstetrician. And sadly, they forgot to call me about my abnormal lab test. I spent 2 months huffing and puffing, 2 months in between visits. And they said, well, didn't we call you from the office? And I said, no. I was so tired and short of breath, and I was going from room to room seeing patients as a doctor, and the patients were feeling sorry for me, asking if I wanted to sit down. And I realized if I had had access to a patient portal, even better if someone had sent me an email reminding me to check my labs, I would have found out that I was terribly anemic, I would have gone on vitamins and iron, and I wouldn't have been huffing and puffing for 2 months in the hospital as a doctor. That's my first vignette. The second is about my mother. Now, many of you were in the age where we're either caring for children or we're caring for elderly parents. My mother lives in another state. When she was diagnosed with breast cancer, I flew down and helped her with some of her doctor's appointments, but I could not attend all of them. And you know when you call your parent and you get the sense that something isn't right, and your parent says, oh, I'm fine, don't worry. And then you hang up and you think, something's going on. And then you call back again and your mother says, I'm fine, don't worry. Yes, it does hurt, but I'm fine. You know, and then you think, let me try calling some of the doctors, let me try and figure it out. It took me months of telephone calls to figure out that my poor mother was on a medication that was too high. She was seeing doctors from many different health systems, none of them were communicating, and my mother suffered because of this. If I had had access to a patient portal that allowed a caregiver access, like we now have here at the University of Washington, I could have helped my mother much sooner. Now, the reason I've kept the lights dimmed is that there's a third person in this picture, and I want to make certain you see Maggie, our dog. She is a rescue dog, very sweet. And a decade ago, I received emails from our vet's office saying, you know, it's time for her vaccinations. They were so organized. I wish that my pediatrician had been as organized. For those of you that are parents, every September, I always wondered, okay, does my son need vaccinations, yes or no? Do I have to hustle and get him in? And I never knew, and there was all those forms you had to get filled out. Wouldn't it be nice if in medicine we were as organized as my vets? Then the story continues about my dog, though. Seriously, a decade ago, I received an email inviting me to sign up for a patient portal so I could access my dog's medical records. We have a ways to go in medicine, and I want to explain perhaps why we're behind the vet's office. And this is what I would like to cover in my presentation. I need to start by explaining the history of medical records. What is their purpose and goal? What is in the medical record? Then I want to share with you some of our research, and we call it OpenNotes because we opened the notes, everything, including the doctor's notes, to patients. Then there are a lot of myths about medical records, so I want to debunk them. And then I want to close with thoughts about the future. So stepping back in time, this shows a picture of a very caring doctor. The doctor's at the patient's bedside, probably pondering the signs and symptoms, wondering about the differential diagnosis. The doctors then wrote very detailed notes. The notes were for themselves. In other words, the doctors wrote down, what they thought was going on with the patient, what they had tried. And the notes weren't for other people. They were just to remind ourselves about the patient's status. Now, I'm going to show you an example medical record from 100 years ago. Some things don't change over time. Our handwriting. These notes were rich in the patient narrative, rich in comments about the social history, the family history. Over time, though, they've turned into this. This is an example medical note. Sadly, you can find these things because people put their own medical records online, so you can find these to put into talks. We are now using templates. Everyone is using abbreviations. And you can't read the fine print, but in this one area up here, there's nothing written. I love being a doctor. This area is the social history and the family history, and doctors are leaving it blank. I feel like the medical records, people are getting so busy, they're sometimes losing the richness and the importance of things that need to go in the medical record. But the record has expanded over time from a single handwritten note for one doctor now to a note that a doctor has to communicate with other doctors and with other health systems. We now have more tests, and it has gotten very full and very complicated. The notes are now filled with so much that they are big. For those of you that are healthy and you've noticed you have a chart this thick in the old days when they had the paper charts, let me share with you some of the content of medical charts. I've listed them here, and this is only a partial content. It starts with demographic information. I need to know your telephone number and your email in case I need to contact you. Then it includes every single note. Every single time you see a doctor or a nurse or a therapist, a note is written. Every phone call is documented. All those emails my patients are sending me, they're in the records. Then it just goes on and on. Allergies, medications. By the way, once, and I'm hoping you will all sign up for your medical records, once you go on, you will probably notice that the medication list has errors. We need you to help us. We really do need your help. As you go down here, you'll see towards the bottom things like laboratories. You all can sign up for patient portals now, and you can click a button and see all of your lab tests. You can see radiology reports. In some of the patient portals, you can click and actually see the beautiful images themselves. Pathology reports, and then at the bottom, I see a lot of patients, and they've already been seen by doctors at 2 or 3 other health systems. Everything, if I can sign up and if it's compatible, from that system will be shoved into my medical record. So you can imagine how voluminous this is. It just goes on and on and on. Now, I've described the medical records, the goals, all of the content. But have any of you actually read your medical record? Anybody raise your hand if you have? A few people have. Okay, how many people have really wanted to read your medical record? Okay, sometimes TV shows get it right in describing what the patient feels like. I'm a little embarrassed showing this TV segment because it's not very flattering of physicians, but with that introduction.
The doctor will be with you in a moment. Difficult.
Elaine, you shouldn't be reading that. Now tell me about this rash of yours.
Well, you know, I noticed that someone wrote in my chart that I was difficult in January of '92, and I have to tell you, I remember that appointment exactly. You see, this nurse had asked me to put a gown on, but it was a mole on my shoulder, and actually I'd specifically worn a tank top so that I wouldn't have to put a gown on. You know, they're made of paper.
Well, that was a long time ago. How about if I just erase it? Now, about that rash.
But it was in pen. You fake erase.
All right, Miss Venice. This doesn't look too serious. You should be fine.
What are you writing? Doctor? You are not going to believe what happened to me at the doctor's office today.
Not the gown again.
No, I was looking at my chart and it said that I was difficult. Why would they write that?
They've gotten to know you.
And then the doctor writes more stuff down there and he doesn't even look at my rash.
Why don't you find a doctor that doesn't know you're difficult?
Elaine, you really didn't have to put on the gown.
Oh, it's my pleasure. I love these. You know, in fact, I've got one at home. It's perfect when you just want to throw something on. Hi.
All righty. Let me just review your history before we begin.
Oh, where did you get my chart?
From your last doctor. Standard procedure.
You know, I can tell you my whole history. Let's just...
Okay, let's take a look. Well, that doesn't look too serious. You'll be fine.
I mean, please, it's really, really itchy.
We've come a long ways. We now are opening up medical records to patients. Sadly, we've not yet done enough research on the topic, though. I want to now move to the second topic, which is, let me describe some of the basic research that's been done on medical records. And I want to start with an article published 50 years ago in the New England Journal of Medicine. You guys are medical students. You've heard about New England Journal of Medicine, high-profile journal. And they had these pictures. Here. On the left is a patient, and they had 100 patients sign up and type into what is described as a small, high-speed digital computer. Okay, this is 50 years ago. And then on the right is the cathode ray screen that they looked at. And it basically asked them, have you ever had an allergic reaction to penicillin? Yes, no. And the goal of this paper was to enlist patients to help us improve the medical record, to offload work from the doctor, and to have standardized, high-quality data. Brilliant idea. 50 years ago. As I read through this paper, there was a sentence that struck me as sad, and it was in the discussion. And let me share with you this sentence. Remember, you've been attending medical school, you've been hearing about the rich research we've been doing at molecular science and genetics and parasites. We're talking about medical records, and we do not do enough research on this topic. This is the sentence. Neither the method of history taking and recording, nor the reliability and usefulness of the data collected has been studied as rigorously as the other tools of clinical medicine. There really hasn't been a lot of research on medical records. This is the glue that holds together medical care. This is big picture. This is important. Well, I'm an optimist, and I want to say that 50 years later, I think the next generation of physicians, they're going to help us. They're going to help us get this right. This is Mikhail Anderson. He is a second-year medical student here at the University of Washington. He spent the summer working in our research group. Mikhail basically had patients come a little bit early to their appointments in the clinic, and he had a very small portable computer, and he had them help write part of our notes. He said, just type the note for your doctor, explain why you're here, what you want the doctor to pay attention to. And so when I would show up in the room, part of my note was written. Patients loved it. I have to admit the doctors were a little worried because we get an onslaught of all kinds of information coming at us. But it actually was helpful. It helped to sort of prioritize things. It helped to connect us with patients. It was marvelous. But I do want to say there's going to be a lot of bumps in the road ahead. And let me continue now describing some more research that we have done that kind of has helped start this whole topic of OpenNotes. This is a description of a study that we started in 2010, and it was at 3 institutions. One was here at Harborview. We did this in the Adult Medicine Clinic and in the Madison Clinic. The second was at Beth Israel Deaconess. This is a Harvard affiliate hospital, and their clinic patients pretty much all have PhDs. Then the third site was in Geisinger. This is a very large health plan in Pennsylvania. Each of the 3 sites had different electronic health records. And after this study, I need to say that we have gone from these few thousand patients in this study that I'm going to describe to right now, in just a few years, more than 6 million patients in the US now have access and are actively using portals and are looking at their doctor's notes. And some of them are going to be helping their doctors write notes. So for the methods, basically, this was a study where we did a survey of patients and a survey of their doctors. We then flipped the switch, and we gave all of the patients access to everything in their electronic medical record. Now, you may have heard of patient portals, and sometimes a, quote, patient portal will give you access to emailing your doctor. But this was access to everything. At the end of a year, we then surveyed the patients and the doctors again. We had 12 months of sharing notes, over 100 volunteer physicians, and over 19,000 patients. We asked 3 very simple study questions, and they're listed here. First, does OpenNotes help patients become more engaged? Secondly, is OpenNotes the straw that breaks the doctor's back? I have to admit, some of these doctors were a little bit hesitant about this study. And I think as I continue through, you'll understand why. And then the third study question we asked is, at the end of 1 year, would the patients and the doctors want to continue? So very simple study questions. And this was published in the Annals of Internal Medicine. What did we learn from the patients? They want the notes. They were not scared to read the notes. More than 80% of them read the notes. In fact, we found that if we sent them an email reminder, more of them read the notes. Interestingly, they shared the notes, 20 to 40%, depending upon the clinic. When we asked them at the end of the year, they said, oh yes, I shared this with either my partner or with my mother. And then they reported all kinds of benefits. And these are some of the benefits. 3 out of 4 patients said that they felt more in control of their health. They felt that they had better recall of what had happened in the doctor's appointment. I mean, how many of you have been to see a doctor, you go home and you think, okay, wait, did the doctor say to take this in the morning or the evening? They could open up their computer and get reminded of what was actually said. They felt that they had an improved understanding. They felt that they could be better prepared for future appointments. And then finally, they figured out their medications. 80% of them said that they thought they could do a better job taking their medications right. They actually figured out what some of the medications were for finally. This was very important. Now, the patients were all gung-ho and loved this. I told you that at the beginning, some of the doctors were hesitant. Let me show you the results of just 2 survey questions when we asked the doctors at baseline, pre-study, and then afterwards. These are the 2 questions. One is, we asked the doctors, do you think because of this OpenNotes that you're going to spend more time addressing questions outside of visits? And then we also said, do you think you're going to spend more time writing the notes and editing them? Remember, we have never written our medical notes with even the idea that patients are reading them. We write our medical notes for us and for other doctors. You'll see before the study, 42% of the doctors, they were worried about these things. At the end of 1 year, look how these dropped, 3%, 11%. At the end of the study, the doctors realized that they were even seeing some benefits. Their patients came in more engaged. It was a different kind of partnership. So the bottom line after 1 year is that 99% of the patients, when we asked them, they wanted to continue. In addition, we asked a survey question, and 85% of the patients said that the availability of having these patient portals and OpenNotes, it would affect their future choice of a doctor. And remember all those hesitant doctors at the beginning? Not one of them asked to stop at the end. They spoke with their feet. They continued. And I'm proud to say at the University of Washington, under the leadership of the University of Washington physicians, we now have OpenNotes available in all of our clinics, all of our notes, something like 3 million notes a year. This shows a map of what's happening outside of just the University of Washington. This lists all the different hospitals, health systems that this is being offered, Stanford Hospital, MD Anderson. You'll notice a whole bunch of little orange dots throughout the country. Those are VA hospitals. Even the VA system has a little blue button that vets can sign up and access their own medical record. You know, they may live in Minnesota and then spend the winters in Florida. They can access all of their records themselves. Let me move on now to myths. And I'm going to cover, I think there's 7 of them that I'd like to cover. The first is that patients are not allowed to read their medical record. I want you to not feel that you're asking something you shouldn't. It is not rude to ask to read your medical record. There are some laws backing you up. Even though legally the medical record belongs to the doctor or the health system, you know, there are some rules in place in the United States that within 30 days, we need to provide you your medical records. This shows what the University of Washington patient portal looks like. You sign up for it. You get a secure login. You create your own password. And you go to here, and you can push any of these buttons on the left. Say you saw a doctor at a clinic at the UW Medical Center. You click there, and it'll pull up a screen. You can click on any of the notes. It'll click on a tab. You can push the lab buttons. You can look at the radiology reports. Everything's there for you. You just need to sign up. So that's myth number 1. You can feel free to ask to see your medical records. Myth number 2, access is available to all patients regardless of age. This one I found interesting. And so I'm going to share a personal story here again. It's a pleasure when you have a teenager that can drive, because you can then send your teenager to get all of those sports physical exam paperwork done. So I sent my teenage son to get his physical exam for his sports team at the high school, and I think he forgot the forms, so as he was checking out, he asked if he could sign up for the patient portal. You know, his mom studies OpenNotes, so he, of course, asked. And the staff at the clinic said no. And so, of course, my teenage son says, well, why not? And the staff said, because you're a teenager. He says, oh, well, can I sign up my mom? And they said, no. And he says, why not? And they said, you're a teenager. And of course, my son then probably said something like, well, that's stupid. And it actually is, because teenagers are more likely to be engaged technologically than our 80-year-olds who were trying to sign up for the portal. And teenagers, we need to help educate them about their health before we ship them off to college. So I kind of get my son's point. But in the United States, we have a lot of variability among states, as you know, and there's some differences in state laws. There are emancipated minor laws. Some laws, minors can block their parents from having access to the medical records. You know, it all has to do with treatment of sexually transmitted diseases, birth control. And because of this lack of clarity and variability among states, we don't know what to do. And because of this, most patient portals shut down. And this really is sad, because say you're a parent and you've signed up for a portal and you have a young child with cystic fibrosis or diabetes, and you're helping to educate your child, then all of a sudden it turns into a black box. I don't know how to fix this one, but I'm sharing it with you guys in hopes that somebody else will help us fix this. So that's the second myth, and it's a reality. Teens, there's this bubble. On to the next one. All doctors like electronic health records and are ready to share them with patients. The doctors in our studies, they did enjoy this at the end, but it took some encouragement. This shows the results of a survey done of over 2,000 physicians. It was an online survey through social media, so who knows the methods. But I think this shows you that not all physicians know about OpenNotes or have experienced it, and they may not be as positive as we are here in the Pacific Northwest. This is a survey of physicians from throughout the US. The survey question is, should patients have access to their entire medical record, including MD notes, any audio recordings, et cetera? Over 2,000 physicians responded. 34% said yes, always. 49% said only on a case-by-case basis, and 17% said no, never. Now, this shows you that not all doctors are ready for this, but there was two parts to this myth. And the other part is all doctors like EHRs, electronic health records. For those of you that have experienced them, you will understand that you go to see a doctor now, and the computer has almost come between the doctor-patient relationship. We have to figure out how to fix this. I'm going to show you a video. It's a rapping video, but it shows the extent that doctors sort of put together videos online because they're frustrated with this. And definitely, not all doctors like electronic health records.
Yeah, I'm out that paper. No more chasing med records. Writing so illegible that I'll be HIPAA forever. Bought the new software, and though we use it here, I can't use it over there. Different systems everywhere. I used to chart on paper. All of my verbals recorded, mixed up with the ward clerk. Turned diluted to dilaudid, switched me to that EMR. Meaningless abuse. Gee, now catch me at the nurse's station, mashing that F2 key. Notes used to be our story. Narrative, but yo, replaced with copy-paste. Now uploaded ransom note. Me, I'm at that bedside. Focused like a laser beam on the patient. Now come on, I'm treating the computer screen.
Freeze frame. This is the patient's feeling about the computer coming between us. And he did mention that, the computer has come between us. Our notes used to have a lovely narrative. And I'm trying to figure out how to work with my patients. I turn the computer screen. I have the patients watch me while I'm typing. I warn them that there may be a few typos. I've had a few patients offer to type. I thought it would be faster. But I am concerned, and I hope the next generation, they can figure out how to marry sort of a lovely, compassionate practice of medicine with the computer helping us, not coming between. Yet another myth. Your doctor has easy access to all of your records from multiple clinics. I wish it was that easy. You guys may go and get a flu shot at a local store, and then you may break a leg in Utah, and then you may sprain an ankle kayaking out near the ocean. I don't always get easy access to all of that. The different electronic medical records don't always connect. I don't always receive things. I saw a patient last week. She was so sweet. Some of her records did show up. I could not get the blood test that she had done in Bellevue. So she printed them out and brought them for me. We really need the help of the patient. We need you to help serve as the glue. There is a lot of information. Who cares about you the most? You and your caretakers and family members. I think that with OpenNotes, we can get your help. Next myth. Electronic health records are masterpieces. Well, we cover a lot of sensitive concerns, and my advice for our students is that discuss what you write with the patient and write what you discuss. Let the patients know it's going in the records. We now are doing transcriptions and sometimes dictating, and I talk very fast. And so this is an example of one typo. I said sickle cell disease, but I must have said history of sickle cell disease. So sick as hell disease. So these things happen, and you know, I see a lot of patients, and I try to skim over the records, but some of these things sneak in. Now, these are some example terms that I was taught in medical school to use the word disheveled, and I was taught to use the word patient-refused treatments. But to you, that might sound rude and condescending. That is the language that I learned at Stanford Medical School, and we are now trying to change the language that we use, but it may take a few generations. So please keep this in mind as you read your notes. This is a quote here that one of our doctors wrote. The patient comes in full peacock finery. The patient did. They were just dressed to the hilt. But you know, sometimes doctors need to be careful what they write. We use a lot of acronyms. You will see SOB and BS. Shortness of breath and bowel sounds. Since we've started OpenNotes, patients have noted that they are morbidly obese. Some patients have asked us to retract this from the medical record, whereas other patients, and these are usually my patients that I warn and say, did you know if you take your height over your weight and you do the BMI calculation, look on this little calculator, it says you're morbidly obese. And you know, I explain it to them and they're like, oh, okay, I'm gonna print that out and put it on my refrigerator. So it's helpful to them. But I have to tell you that one of the providers, her patients were so upset to find that they were morbidly obese, and they were called obese in the notes, that she started calling them overnourished. I don't know that I agree with that. So because of this, I have started I turn the screen towards my patient and I type it while my patients watch. So they see what's going into it. The final note here is something that one of my collaborators, her husband, went to see his doctor. He's a young man and healthy, and he was disappointed to see that he was described as semi-athletic. All right, next myth. The medical record will be easy to understand. I've published a textbook of biostatistics, now in its 4th edition, and I can truly say that reading the medical record is much harder, much harder. I'm going to share with you an example from a medical record. Here we go, I'll read it to you. 56-year-old AA male is SOB today. Remember that shortness of breath. But denies CP or LE edema, cardiac exam obscured by loud BS. Remember, BS is bowel sounds. Had TTE 2 weeks ago with LVEF 15%, normal valves. Follow up with cards for likely cath and to discuss AICD. Continued diuretic blitzkrieg and check creatinine, as my fear is that he's getting pruned out. So we have our own language. It's, you know, I wish that we could already have a cure for this problem. You're going to go in and read the notes, and I wish that we could have hyperlinks to secure educational material when I have a word that's big and long, like central pontine myelinolysis. You know, you could hover and find out, well, what does central pontine myelinolysis mean? Wouldn't that be nice? Now, I do want to make you feel a little better if some of you were put off by this note, and I want to share with you the inside story about how we doctors have a hard time with the iClinic notes. This is an example iClinic note, and I took this note and shared it with over 50 internists. You know, these are doctors. They're not eye doctors, but they're doctors. And I said, do you understand this note? And I gave them a Likert scale, 1 to 10, with 1, I'm clueless, I do not understand this, to 10, oh, I totally understand it. And let me share with you their results. They were honest. Everybody said, I have no idea what is in that iClinic note. So if that makes you feel any better, Even we have a hard time. In fact, even within some eye clinics, people use abbreviations that other people don't even understand. I am really proud of the University of Washington eye clinics. They now have hired scribes. Their clinic notes are a thing of beauty. They are so clear, articulate, concise. I now understand what's going on with my patient's eye disease. But it has taken us a while to get there. The next myth: all abnormal test results are cause for alarm. When you pull up your labs, you may see highlighted yellow areas such as this. They will give you a reference range, shown here for the blood test. If I ordered 20 labs, one of them will be outside of the reference range. I don't worry about that. But how do patients know? I think we need to come up with a way to help you. You know, you may see something like this and think, oh no, you know, and I may see something like this and say, oh, it's the same old. I'm not worried about it. We aren't yet to the place where we can help you with this. And so we probably need your advice. This shows an example CT scan. And you see this little area here? When you get a CAT scan, you have over 1,000 images. You can find little incidentallomas. And this shows you data. You've probably heard the word incidentaloma. If you did whole body CT screenings, remember when they used to do that? Over a third of those, they found little abnormalities that then they started doing more tests and sticking needles in. If you do MRIs of the lumbar spine, and you look in other areas of the MRI, not the area that you knew there was a problem, in 8% of them, you'll see other little cysts and things. These are incidental findings. And my concern is that you're going to click on pathology or click on radiology, and you'll go to the impression and you'll notice these comments, and it will probably alarm you. I haven't figured out yet how to help you with that. So I need your advice. Now, the final myth is that it's easy to find reliable information on the web and the TV. Now, you would not be led astray with this. 4 hours, no diet, no nutrition, you can change your look like this. But let me share with you a study published in BMJ 2014 in which they selected episodes randomly, and then they randomly selected recommendations within the episodes, and they found that there was not balanced information. You know, when you say there's a benefit, you should explain if it's a little benefit or a big benefit. That was described in less than 20%. And this is for the Dr. Oz show and the Doctor show. They found that potential harms were mentioned in less than 10%. They found that cost was mentioned in less than 15%, conflict of interest less than 1%. But what is more important is that these scientists, when they were reviewing the data presented on these two TV shows, they said, okay, there's a recommendation. Let me go to the evidence and see how often evidence backs it up. And that is shown here at the bottom. For the two shows, they found that they could find evidence to agree with this. 46% for the Dr. Oz show, 62% for the Doctor show. But they found evidence disagreed with what was stated, 15 and 14%. They also found that they couldn't find anything to support it, 39 and 24%. Those are the myths. Now I want to bring us to thinking about the future. I like to close with, I think it's 4 videos. These are of patients. And these will walk through some of the potential benefits of OpenNotes. The first has to do with patient safety. And I think that patients say it better than I can. So let me.
Last year when I was pregnant, I had gone to see my primary care for a checkup. And everything, thank goodness, was fine. But she did notice a mole on my back that she had asked me to follow up with at the dermatologist. But being pregnant, I had forgotten all about it. I remember a few weeks later, there was something nagging at me. And then I was reading through my notes. And I saw the notation that said, referred to follow up with dermatologist. So I did. I immediately went to the dermatologist, and she felt that it needed to be removed. I was so incredibly relieved, primarily. And I felt this sense of safety as well, because I actually had a hand in what was going on with my own health care.
Remember the importance of medications and how hard it is to remember them? Let me share with you this brief vignette.
Even though I'm really healthy, I know that the moment I don't take my pills, something could go bad. And I don't want things to go bad. Having it written down, it's almost like there's another person telling you to take your meds.
Many of us are providing care for either children or elderly parents, and I think this woman describes it very articulately.
My husband is very hard of hearing, and so you can imagine, I mean, even with perfect hearing, I miss what doctors say sometimes, and he is really lost. So it's been a godsend that I can find out what the doctor told him.
The final video is a little bit longer. This includes both patients and their doctors. There's 3 pairs. These are doctors from Harborview Medical Center. And I'd like to close with this video because I think the patients, and as you can see, the interaction and kind of how they're learning about opening up medical records and how to really work with the patients in a new way. So let me close with this video.
We come from a place where doctors tell you. Patients don't ask the doctor anything. You know, he tells you, and you go for it. And so you're sitting idle. The generation after us, they're asked more questions, they want to know more information, and that's why this system is really critical.
Because verbal communication is a tricky thing, and I think a lot of times, because we're trying to speak so quickly and cover a lot of territory, it's nice to have something that is concrete and written down, I think, to look at.
You can look at the comments that Bob writes down, and sometimes, you know, you agree with them, sometimes you don't agree with, but that's the way it is. And, you know, I know what's right for me, and Bob knows what's right for me, and sometimes they clash in that, and then Bob and I talk about it, and it works out. We work things out.
I wish I could read more notes. You know, I wish I could read the therapist's notes, and it's very, very good for me because I've learned a whole lot about my own body since we've been doing this. Like I didn't understand how cholesterol affected you or how liver functions worked.
I have noticed that you're much more interactive at visits in terms of asking questions about what particular terms mean and what the prognosis is for things and specific treatments for things like your hepatitis, which you hadn't been really interested in talking about before.
You've gotten more voluminous with your comments, and I actually see it getting better because there was more information in this one than there was in the beginning ones. I think we're both learning to use the study. We're communicating with each other across the line. Usually you walk in, you walk out of the doctor's office, and you know it's the next patient, and we go back and it's over and done with. So this is a more engaged, overall engaged relationship. It's a completely new kind of relationship, doctor and patient.
You and I used to share information when I would go to your office without OpenNotes. OpenNotes is just like the period at the end of a sentence, okay? It helps me understand what you're doing because I didn't have major surgery, but I know what's happening with me. Okay, so how about that?
As I said, I think it's best to end it with the patient's comment. And I want to make certain that I thank you for inviting me back and also thank the 4 foundations that have been kind enough and real visionaries and supporting this because they care about engaging patients. I'd be happy to answer any questions now. Thank you. Obviously, we have a long way to go in this journey. First question here.
Thank you so much for your great presentation. I have a question about centralized medical records in France, and they have a government-sponsored program that keeps track of everyone's medical records, and then every person has a small credit card type thing that they can take with them to all of their appointments so that they actually bring their medical records with them. And I'm wondering if you support, in theory, something like that here in the United States.
Okay, so the question is, do I support a little computer card that everyone would have their...
Maybe not exactly a computer card, but the concept of having some centralized system that is the same between every clinic in every state in the United States?
You would cure so many problems in the US if you could do that. I don't think I adequately described the challenge we doctors have. Patients are seen in multiple different clinics. They all have different electronic health records. Some people are still on paper and are just transitioning. And it's hard to get all that information in one place. So yes, I would love, especially if the patient could help to kind of coordinate it all. That would be marvelous. And I should add, you brought up France. There are a few countries, Slovakia, there's a few countries that have, the entire country now has OpenNotes, but they have standardized healthcare, so it's much easier. So thank you for your question.
Thank you very much.
Over here.
Yes, I caught that you mentioned transcription of the record.
Yes.
And that puzzled me because I've had doctors now for quite a while who are typing as we talk into their own, so it's all electronic. And so I'm getting the impression that doctors here aren't required to do that. Is that right?
It varies by clinic, it varies inpatient, outpatient, it varies even by physician. We have some doctors that talk very fast and are very terrible typers, and so they may use a dictation program. It automatically dictates, or a transcriptionist. But you're right, most doctors are now typing. I used to dictate in front of patients years ago, and that way the patients could hear what I was saying. And you would sometimes hear them giggling as I'm saying things about their grandchildren or their dogs. But you're right, most doctors now are typing. They may not be happy about it, but they're typing.
Thank you, because I was thinking that my friend who I went to college with, who said she wasn't going to be a secretary, so she didn't take any typing. And I'm thinking, gee, aren't you having to type now?
Well, I have to tell you that some of my patients, they sit there and they watch me type. And I had one patient that said, do you want me to type for you? And I received an email from another patient saying, can you please add me on to your clinic? I know it's overbooked, but can you please see me? And then at the end of her email, she said, I'll even type the note for you, LOL. So we are struggling. We are trying. Question over here.
Yes, how would you feel? I liked the idea of a card that would access any records anywhere in the country. I suppose some people would say that's Orwellian, but I think it's useful. But I'm wondering how you would feel in addition about adding to that record the work of naturopaths, acupuncturists, physical therapists, all the alternative care providers. And I'm going to throw something out here. Some doctors are hostile to having those alternative providers. I think some of them do some very good work.
Okay, that's a great question.
But I'm wondering about adding that, and I'm wondering if it would get hostility from the medical profession.
Well, okay, so the question is a good one. I am encouraging patients to help take control of your health and your records and to stand up and know a little bit more about all the different things that are going on. And I think that if we could develop a system where patients could know about the medical, the naturopathic, and think of those, if you go to the App Store, there's over 10 to 50,000 medical apps. What about uploading some of that information? So I think that we will get there. I need someone to develop it, though. So thank you. Question over here?
I was wondering if you could speak to the concerns and precautions that are being taken as this expands for patient security. It's bad enough when somebody hacks in and gets your credit card number, but if they have everyone's medical records.
Thank you. That is a very good question. Security. When we surveyed patients, a third of them were worried about security. We do banking online, we purchase things online. We warn our patients here at the University of Washington, make certain you shut down the computer, make certain you don't share your password if you don't want to. And we do take security very seriously, I think increasingly so. I wish I had 100% certainty that there wouldn't be problems going forward. But it is something that when patients started using the portals, they realized that part of the burden is on them to make certain that they kept things safe. Over here.
Do I understand correctly
that the Affordable Care Act mandated electronic health records, one, and that two, they didn't mandate interoperability?
Yes. I love the questions you guys ask. They're common sense, they're practical. It's like, can't we get you guys to fix this problem? I have explained to you, so let me summarize now. I have explained to you all of the issues we face with electronic health records and how important they are to your health. I have heard it said that the most underutilized resource in American medicine is the patient. I want to get help from you guys. We need to fix this. Okay, final question here.
I'm less concerned about someone getting my password because I know my passwords are secure, but about network security for these large programs. How is that ensured?
I'm not a tech person, so I don't know how to respond to that. Mika, do you know anything about our tech? President of the UW Physicians Group.
Thank you. That is a great question, and I think that actually is partially one of the reasons that the Affordable Care Act didn't mandate a move towards a more ubiquitous system like the French system. There are different sensitivities around privacy, and it's a very political as well as a practical issue. We haven't solved it, and there have been a number of breaches which you read about in the front page of the papers, in the pharmaceutical industry, in the government, in healthcare plans that have resulted in breaches of and release of large amounts of information. Generally not medical records, usually registration, data, social security numbers, telephone numbers, credit card information, that kind of thing. So it's a big area of concern, and I think it's a balance between the two. We haven't yet solved it. There are very clever people who are trying to break every system that we make that is reasonably effective. So I don't think we have a solution to that. Thank you very much. We're going to take a break, 10 minutes. Please come back for the second part of our How Do We Make Patients Partners in Healthcare Information Management.